Today we'll talk about drugs for asthma and COPD. In addition to your Katsung, I recommend the Global Initiative for Asthma document, which outlines the management and treatment of asthma coming from an international recommendations with experts from various countries, including the Philippines. The updated version is 2020, and you can retrieve this from Google. Consider the case of Mr. T, a 40-year-old athlete, consulting for wheezing with shortness of breath after a morning run. If he has a medical history significant for asthma in childhood, for which he was using salbutamol inhaler about 3 times a week, if the symptoms abated until about last month, where he woke up with asthma symptoms about twice a month, what would be your impression of his breathlessness? Does Mr. T require asthma maintenance medications? If we go by the GINA guidelines, our goal for Mr. T is for him to live a normal life. Many asthmatics have excelled in athletics, in the Olympics, in various careers with adequate control. Be Adequate control is defined by the absence of symptoms, no limitations of activity, minimal reliever use, and a minimal decline in lung function. The secondary goal, would be to prevent future risk, which means that we don't want Mr. T to have frequent exacerbations that lead to instability or worsening, even loss of lung function. And we want to be able to achieve this without the adverse effects of medication. If we would like to achieve the goals of GINA for the management of patients, our goal for this session would be to determine the appropriate drugs for the management of COPD and asthma based on the pharmacodynamic and pharmacokinetic features, and to advise patients on possible adverse effects and monitoring needs to evaluate efficacy. Consistent with the case of Mr. T, asthma is a chronic and recurrent episodic airway disease characterized by inflammation of the airways leading to thickening of the interstitium, goblet cell hyperplasia leading to mucus hypersecretion, and smooth muscle constriction causing bronchoconstriction that results in recurrent wheezing. Asthma can be treated presumptively with two major groups of agents, the primary drug being your anti inflammatory agents, the prototype of which is your corticosteroids. Inhaled corticosteroid therapy is the preferred route for treatment of asthma. Alternative drugs include your leukotriene modifiers, which are considered your steroid sparers, which can inhibit secretion of the pro inflammatory leukotrienes that lead to bronchoconstriction. Other alternatives will be your chromones, degranulation inhibitors, such as your mast cell stabilizers. More recently, antibodies, which target your IgE, your interleukin 5 and interleukin 4, are important as anti inflammatory agents where steroids are not effective. The other arm of the management of asthma will be your bronchodilators, and there are just three important groups that you have to remember: your beta 2 agonists, your muscarinic antagonists, and methylxanthines. In the last year, the radical change in management of asthma was ushered in by GINA, whi- which overturned over 50 years of recommendations, which start with the short acting beta agonists as the primary bronchodilator for mild asthma. Today, your short acting beta agonists are recommended to be used in conjunction with inhaled corticosteroids, even in mild asthmatics. When we discuss asthma drugs, therefore, we will now turn to combination preparations as the mainstay for mild to more severe types of asthma. The new guidelines specify that the initial controller of choice from well controlled all the way up to the poorly controlled asthmatics will be your inhaled corticosteroid and formoterol combination. What will differ as the asthma progresses in frequency and severity will be the dosage, which increases in each step, or the addition of other controllers that may augment the action of your ICS formoterol combination. We will take the augmenting drugs, and the final step, the anti IgE, anti IL-5, and anti IL-4 modes of therapy in the next slides. Let's start with the beta 2 agonist. This is the drug of choice for asthma. It acts as a sympathomimetic agent, meaning it can cause bronchodilation. The main mechanism for the beta 2 agonists will be the eventual signal transduction, which leads to inactivation of your myosin light chain kinase. These effects are mediated by your Rho kinases. An important feature of the pathway will be the activation of the sodium and hydrogen exchanger. As an important effect of activation of this exchange regulatory protein will be the end effect of causing hypokalemia in patients who have chronic use of the beta agonists. Other effects of your salbutamol will come from inhibition of your mediator release from your basophils, mast cells, lung tissues, and inhibition of the pro-inflammatory cells, your eosinophils, macrophages, T lymphocytes, and bronchial epithelial cells may have some effects in inhibiting the inflammatory cascade. Activation of your phosphokinase may explain other peripheral effects. Aside from smooth muscle relaxation, you may have GI relaxation. The presence of beta receptors, which may be activated in the skeletal muscles, can lead to tremors, a common adverse effect of beta 2 agonists. Inhibition of histamine release in the mast cells is favorable in inhibiting the bronchoconstricting effect of your histamine. In the endothelial cells, Tran- Transient decreases in oxygenation may result from this vasodilation, and therefore, in patients who are already hypoxemic, supplemental oxygen can be important to prevent further decline in oxygenation. In the liver, glycogenolysis can cause a transient increase in glucose and some insulin uh, a decrease in insulin sensitivity. One of the more predictable beta agonist adverse effects will relate to the ability of your beta 2 to cause peripheral beta 1 reactions. Despite the selectivity of your beta 2 selective drugs, some cardiac effects may be seen even at normal doses, and this may translate into increased contractility, heart rate, conduction velocity, and smooth muscle relaxation. Formoterol then is a LABA with a short onset of action. It is comparable in its short onset to your short acting beta agonists, which remain to be recommended as important adjuncts to the management for breakthrough episodes of bronchial asthma while the patient is being maintained on your maintenance corticosteroids. Available in the market will be your clenbuterol, salbutamol, terbutaline, metoprolol, and bambuterol. Duration of these SABAs will be limited to range from 3 to 6 hours. Among the SABAs, your terbutaline has a high beta 2 specificity for your beta 2 adrenoreceptors. Let's focus first on formoterol. The drug in combination with inhaled corticosteroids is the first line because it is a beta agonist which acts to produce bronchodilation in a dual fashion. It has a fast onset but a long duration of action. The action of formoterol is said to be equipotent with other comparable short acting beta agonists. Its long action occurs because of its long chain, which forms a depot in the cell membrane and progressively leaches out to produce a duration, a longer duration of action. Another long-acting beta agonist, which is salmeterol, is comparable to your formoterol in its long duration of action, but it has a very delayed onset, making it less ideal for providing symptomatic relief in an acute exacerbation. Comparing with your formoterol, salmeterol achieves its ability to produce a long acting action because it rapidly diffuses at an external active exocyte. The long duration of formoterol, which is found in the bottom of this slide, can be explained by the long side chain, which, as we said, is able to insert itself into the cell membrane to produce a depot, while your salmeterol has an even longer chain, which allows it to bind at an exocyte. Both have beta 2 receptor specificity and prolonged duration of action. The advantage of formoterol, however, as we said, was its ability to produce a short acting effect as well. Although formoterol will have the edge of a shorter onset of action, your salmeterol is still in the recommendations as a long acting beta agonist with a higher beta 2 selectivity compared to your formoterol. Another option recognized by the guidelines will be the combination of a short acting beta agonist with an ICS LABA combination. And sermeterol can be uh, and salmeterol remains to be one of these options. Among the various SABAs, your salbutamol, also known as your albuterol, has the highest relative selectivity ratio compared to the other SABAs. Their onset and duration are comparable, except that for isoprenaline, there is a shorter duration of action. In contrast to the compact structure of your short acting beta agonist, your SABA, there is a new drug, your ultra long acting beta agonist, indacaterol, which, with its very long structure, can also extend the duration of action beyond that of formoterol or salmeterol to 24 hours, with a very short onset of action comparable to your salbutamol. Indacaterol has the greater cardiovascular safety margin than either formoterol or salmeterol and is indicated in both asthma and COPD. Finally, an advantage of your beta agonist will also be in improving the glucocorticoid response. This is believed to result from the activation of your MAP kinase pathway, which may increase the glucocorticoid receptor translocation into the cell membranes, increase in your glucocorticoid response element binding protein, which increases your transcription of anti inflammatory factors. In summary, we can explain many of the adverse effects of your beta 2 agonists by looking at the extension of the primary mechanisms of action. Extension of your beta 2 effect into the beta 1 receptors causing your tachycardia, palpitations, extensions of your beta 2 stimulation to your other cells that contain your beta receptors will cause your nervousness, your CNS effects of restlessness, CNS stimulation, hyperactivity, and insomnia. A transient decrease in your oxygenation may explain initial lightheadedness. Your weakness and muscle cramping may relate to some of your electrolyte changes, and these may also be very rarely due to your hypokalemia. Hypokalemia may be found rarely with chronic use. Some patients may also have an allergic reaction causing paradoxical bronchospasm and increased chest pain with the use of your beta 2 agonists. If you had chosen to nebulize Mr. T with salbutamol and he complains of worsening dyspnea, increased wheezing, and you observe a drop in oxygenation, what might be the cause of this reaction? If we go by the mechanisms of your beta 2 agonist use, we may still rule out the possibility of a hypersensitivity reaction to your salbutamol. Alternatively, we can also look at what might be happening if the patient suddenly complains of weakness of the lower extremities after an nth dose of nebulization. What adverse effect might cause this? If you thought of hypokalemia, then you're right. A rare effect of your beta agonists may be hypokalemia causing muscular weakness, especially beginning in the lower extremities, but in severe cases progressing to cause respiratory suppression. It may be important to recognize these adverse effects due to the mechanisms of your beta 2 agonists. A known downside with the use of beta agonists will be the presence of inter-individual variability. This is often explained by beta receptor desensitization. What it means is that with constant use over days or weeks, there is down regulation of the receptor, possibly as an autoregulatory process. It's believed this may be due to uncoupling of the receptor from the adenylate cyclase pathway, internalization of the uncoupled receptor, or downregulation of its activity. And what this means for the use of beta block agonists is that close monitoring of the effects should be done to determine if this develops. Can you see a difference between diagram A and B? It's essentially the same molecule, which represents a receptor, the only difference being the downturning of one portion of this molecule. Individual variability may also be explained aside from your downregulation of your receptors by your beta 2 adrenoreceptor polymorphism. Substitution of arginine in position 26 of the beta receptor may result in increased asthma severity and reduced bronchodilator response. Similarly, glycerin 16 substitution downregulates your receptor to result in increased airway hyperreactivity, increased nocturnal symptoms for more severe asthma. The good type of polymorphism would be glutamate substitution at 27 position, which is associated with increased agonist mediated responsiveness and less reactive airways. So, beta adrenoreceptor polymorphism is another reason that when giving your beta agonists, close monitoring should be done to measure the efficacy of a single dose. Another modification pays attention to the selective effects of the isomers. Your level butyrol is a purified R isomer, which will have the advantage of greater bronchodilation for many patients. It has been shown that the S isomer of salbutamol, which coexists in a regular solution of your salbutamol, will increase the pro-inflammatory cytokines promoting your smooth muscle contraction, which counteracts the anti-inflammatory effects of steroids. The question is whether your level butyrol is superior in its activity to your racemic mixture. What they see in the recommendations is that there is no selective advantage except that there may be less adverse effects for those who are very sensitive to the effects of salbutamol. Levolbuterol is more expensive than salbutamol, but their peak effects may be comparable. Before we leave the topic of beta agonists, we have to make a special mention of the non-selective sympathomimetics such as your epinephrine. Epinephrine can achieve the effect of bronchodilation, but it will do so at the expense of other effects, particularly the beta 1 stimulating effect, which may result in tachycardia, increased lipolysis, increased myocardial contractility, and release of renin. Your adrenergic 1 receptors may result in vasoconstriction, increased peripheral resistance, leading to an increase in blood pressure, mydriasis, and increased closure of your internal sphincter of the bladder. The effect of vasoconstriction may be and increased blood pressure may be important when there is impending respiratory failure. Your alpha 2 adrenergic effect will inhibit norepinephrine and acetylcholine release as well as inhibition of insulin. The use of epinephrine is reserved for life-threatening bronchoconstrictive episodes where the added effect of boosting your blood pressure may benefit patients who are in impending failure or shock. For patients who may have a hypersensitivity reaction to your SABA, the alternative will be a SAMA, a short-acting muscarinic antagonist. We have mentioned the sympathetic effect of beta receptors stimulation, which results in bronchodilation. By inhibiting the opposite, your cholinergic effect, using your anticholinergic drugs, you may achieve the same type of bronchodilation. Ipratropium and oxytropium are the prototype drugs for your SAMA, the anticholinergic, which acts particularly on your M3 receptor subtype, which is located in exocrine glands and the smooth muscles. Blocking your M3 will result in inhibition of the downstream pathways leading to bronchoconstriction. The ability of your ipratropium to produce bronchodilation will lie in its inhibition of your IP3 and diacylglycerol pathway, which is responsible for increasing the intracellular calcium, leading to activation of your myosin light chain kinase. By blocking this pathway, your usual triggers for your bronchoconstriction will be inhibited. The drawback of inhibiting your cholinergic pathways will be the presence of more sympathetic effects, including stimulation of your nervous system, your nausea, serostomia, stomach upset, palpitations, insomnia, trembling, blurring of vision, urinary retention, and nasal congestion. The result of your hypertropium may be rashes or urticaria stomatitis. The onset of action of your ipratropium will be 1 to 3 minutes after administration, comparable to your salbutamol, but its peak will be at a later time at 1.5 to 2 hours compared to 30 minutes to an hour in salbutamol. Duration is comparable at 4 to 6 hours. Like your beta agonists, interpatient variability can be present with your ipratropium. Ipratropium with salbutamol combined preparations are now available. The advantage of combined preparations will be a synergistic effect. The antimuscarinic effects are seen to be more proximal, while beta receptors effects will be more in the distal airways. so that the combined effects are known to be advantageous. So far, we've discussed your SABA and LAMA, then your SAMA, short-acting muscarinic antagonists. The last option for an acute reliever will be the methylxanthines, mainly your theophylline and doxophylline. These are generally last line, and we'll find out why. The theophylline group will share the mechanism of increasing your cyclic AMP. Your SABA will increase cyclic AMP by activating your adenylyl cyclase to convert your ATP to cyclic AMP. The other end of the picture from your theophylline will be an increase in cyclic AMP by decreasing the breakdown of your cyclic AMP by inhibiting your phosphodiesterase enzyme. The increase in cyclic AMP will have the desired effect of inducing your bronchodilation. At low doses, your theophylline may also have your anti inflammatory action by inhibiting the late response to antigenic challenges. This dual effect makes it an effective drug. So, why is it considered the last line? Theophylline has multiple mechanisms for arresting inflammation in the airway via inhibition of several cytokines, interleukins, decrease in prostaglandins, tumor necrosis factor, nuclear factor kappa beta, inhibition of the intracellular calcium, and increased apoptosis has been noted. Increase in your histone deacetylase activity, an offshoot of the downstream cyclic AMP reactions, will increase the secretion of your glucocorticoid hormones, increasing the transcription via your cortisol binding protein transcription factors. These advantages may make your theophylline an ideal drug. But the reason that the advantages of theophylline are put in the back seat will be the multiple adverse effects, even at small doses and small increments of increase in the dose. There is an increased potential for various effects, not only in the central nervous system, but more significantly in your cardiac arrhythmias, tachycardia, occasional premature ventricular contractions. With increased doses, you may have ventricular tachycardia, frequent premature ventricular contractions, and seizures. Theophylline has a weak diuretic effect and may reduce your blood viscosity. It may strengthen diaphragmatic contractility in patients with COPD, giving it a slight advantage. Your theophylline is metabolized in your liver by your cytochrome enzymes, and drugs that can decrease the induction of your microsomal enzymes can potentially cause an increase in the activity of your theophylline by decreasing its breakdown. These include some of your sedative barbiturates, anti-seizure carbamazepine and hydantoins, anti-TB drugs, your isoniazid and rifampicin, the effect of smoking, and your antifungal ketoconazole and your sympathomimetics. Increased levels may be noted in drugs that potentiate your your breakdown of your theophylline, including your beta blockers, calcium channel blockers, ciprofloxacin, the presence of corpulmonal, macrolides, isoniazid, contraceptives, and thyroid hormones. The preparation used at the emergency room will be your aminophylline IV, which is only added if there is no relief with your standard bronchodilators. Immediately re- Immediate release theophylline may also help in an acute attack. The use of timed release medications, however, will be more common as a preventer. Caffeine can be converted to theophylline and vice versa, and therefore, food and beverages containing caffeine should be avoided. Extremes of dietary protein, carbohydrate, and charcoal intake may decrease its effects, and because of its diuretic effect, advise water when taking your theophylline. Luxofilin is a similar drug to theophylline, but with a heavy side chain, which has the effect of improving your tolerability and increasing the risk to benefit ratio, causing less cardiovascular events and drug interactions. There is no interaction with histone deacetylase, and it is unable to antagonize your and calcium activated potassium channel. The drug is well absorbed and metabolized by the liver and has become the alternative drug for patients who are sensitive to the cardiac effects of theophylline. Reproterol increases the advantage of your beta 2 agonist in increasing your cyclic AMP, with the advantage of decreasing the breakdown of cyclic AMP with theophylline. Dual benefits can produce a synergistic mode of action on adenylyl cyclase, but the drug is reserved for use in patients who are uncontrolled by traditional bronchodilators. It is not used in children under 6 years of age. While the drug combines the mechanisms of both beta blockers and theophylline, adverse effects are also multiplied. The usual tachycardia, tremors, headaches, nervousness, and rash, which are characteristic of your beta agonists, may also be compounded with the presence of allergic potentials with your angioneurotic edema, bronchospasm, flushing. Hypokalemia can also be a problem. Consider the case of Mr. T, a 40-year-old athlete, consulting for wheezing with shortness of breath after a morning run. If he has a medical history significant for asthma in childhood, for which she was using salbutamol inhaler about 3 times a week, if the symptoms abated until about last month, where he woke up with asthma symptoms about twice a month, what would be your impression of his breathlessness? Does Mr. T require asthma maintenance medications? In summary, bronchodilators are effective reliever medications by acting on the smooth muscle contraction that leads to bronchoconstriction. The mechanisms by which these drugs work will be complementary to each other. Your SABA by via acting via your cyclic AMP and your methylxanthine by decreasing breakdown of your cyclic AMP via your inhibition of your phosphodiesterase, and your anticholinergic drugs by contributing your decrease in your sympathomimetic tone. By understanding the mechanisms of each bronchodilator, combined use of these mechanisms may potentiate the effect of single preparations of bronchodilators, especially in asthmatics who are recalcitrant to single therapies.